Yes, so the use of FLT3 inhibitors following transplant is, in our practice, a standard approach based upon several different studies that show benefit for these patients that receive maintenance therapy, mainly, again, with Gilteritinib. Some of the other agents are coming along as well. A lot of it has to do with toxicity concerns, how well these are tolerated. The duration of therapy is a controversial topic. In our practice, generally, we continue for 2 years following transplant, assuming that the patients tolerate these therapies. And we do monitor these patients with PCR-based assays looking for the mutation. In those that we find that are FLT3 negative, in some situations we may consider stopping early, mainly due to toxicity concerns. That's the major issue that our patients are facing.